Good afternoon, and thank you for joining us for another edition of Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue and Transplant Education Program, the Pennsylvania Avenue Baptist Church, and of course, BlackDoctor.org. I'm your host today, Suna Halley, and I'm a program manager at the GW Liver and Pancreas Institute for Quality. Today's presentation is entitled Liver Terms You Should Know by Dr. Zahid Vahora. Dr. Vahora is our medical director of liver transplantation at the George Washington University Hospital. Dr. Vahora, who is a Pennsylvania native, specializes in the management of many liver diseases to include portal hypertension complications, liver cirrhosis, alcoholic liver disease, and managing complications after liver transplantation. Outside of medicine, he enjoys a variety of sports, including soccer, football, and baseball. Dr. Vahora is an avid runner who also enjoys the outdoors, whether it's fishing, hiking, or kayaking. On today's panel, we have our very own Dr. Keith Melanson, the Chief of Transplantation at the George Washington University Hospital. And joining us later will be Dr. Clive Callender, Professor of Surgery, and founder of MOTEP, the Minority Organ and Tissue Transplant Education Program. Without further ado, we welcome Dr. Zahid Vahora.
Good afternoon. Thank you so much for the opportunity. I know typically this is a kidney talk, so I'm just kind of diving in a little bit more about the liver here, since that is my expertise. So we can pull my slides up. Perfect. All right. So we're going to go over liver terms everyone should know. As Suna introduced me, I'm the medical director of our liver transplant program here at George Washington University. And once again, thank you so very much for the opportunity. We'll kind of go ahead and get started here. First and foremost, I want to kind of go over a term, a word that is commonly heard and commonly used, but also commonly misunderstood. The word hepatitis. I'm sure as many of you may have heard this term, you often think that you have something's associated with it. Most times people think most of the viral hepatitis A, B, or C. But really, the word hepatitis is a very general term. If you break it down, hepa meaning liver, itis meaning inflammation. So the word hepatitis just means liver inflammation, which also can mean elevated liver enzymes. And we'll touch on the word liver enzymes as well. Now, I often tell patients, just like there's many flavors of ice cream, there's many flavors of hepatitis. There's viral hepatitis, A, B, and C. Autoimmune hepatitis. There's certain genetic causes of hepatitis, alcoholic fatty liver, and of course medication-induced, among others. But main thing here is that hepatitis just doesn't mean viral hepatitis, but as we'll kind of go through many of the other hepatitis, you'll see it just means inflammation of the liver, and there's many causes of hepatitis. Kind of moving forward, we touched on liver enzymes. When oftentimes patients, when we say, they may say, hey, a doc told me my liver enzymes are elevated. What do they mean? So when the liver enzymes are elevated, most of the three main ones that they're talking about are the AST, ALT, and alkaline phosphatase. I've abbreviated the AST and ALT because no one really talks about that long name that really kind of goes with it. But it really means that if they're elevated, it means there's inflammation in the liver. There is a hepatitis. Now, when patients often talk about liver function, the true functions of the liver are the PT-INR lab test, the albumin and bilirubin, mostly because these will tell us if there's any kind of more damage to the liver, because the liver makes these products specifically. So if there's derangements or abnormalities with these, it can be it's a marker of a little bit more serious of an issue. So going back to hepatitis here, most hepatitises are chronic progressive diseases. The longer something is causing inflammation in the liver, the more opportunity it has to do damage to the liver. So regardless of the cause. So when we say that there's the stages of the liver, the stages are essentially 5 stages. And as you can see here, it goes from, and the amount of scarring, another word for scarring that we use medically is called fibrosis here. So as inflammation, regardless of the factor, alcohol, viral, fatty liver, others, cause inflammation. The inflammation goes from it causes inflammation, and then that causes fibrosis or scarring over time. So it goes from stage 0, F0, 1, 2, 3, and 4. 4 is cirrhosis, and we're going to talk a little bit about cirrhosis as well. And cirrhosis is irreversible, so that's stage 4 liver disease. If someone has, any kind of liver disease, any stage of liver disease prior to cirrhosis, prior to stage 4, it is potentially reversible as long as we treat the insult, the initial cause right here. Go forward. So again, to cirrhosis. Now here's a patient we transplanted. We took out his cirrhosis liver. You can see it's a very scarred down liver. It's not very smooth like this. So cirrhosis means end-stage liver disease. It's also known as a stage 4 liver disease. Once you get the cirrhosis, it is irreversible. But what's the problem with cirrhosis? Why is cirrhosis an issue? It's an issue because at this point, the liver, there's too much scar tissue, and the scar tissue doesn't do the normal work of the normal liver. And the scar tissue replaces the normal functioning liver cells. So then you develop the complications of cirrhosis, which we'll talk about. But the main thing to remember is once you have cirrhosis, that cirrhosis is there to stay, unfortunately. So usually when I say there's two sides of the coin when patients have cirrhosis, it's compensated versus decompensated. So what does this mean? Compensated means yes, you have cirrhosis, or a patient has cirrhosis, but the liver is compensating. The liver is still able to do the work the body needs it to do. And then decompensated cirrhosis, and sometimes you may hear a doctor say this, decompensation means now the liver can't do the work the body needs it to do. And what happens then? Well, then that's when you see these major complications of liver cirrhosis. You can see patients who develop vomiting of blood because in the esophagus here, you can see here in the picture, they develop these varices, dilated veins that can rupture and hemorrhage, and that can be life-threatening. They can develop a kind of a brain toxicity where the liver is, we call it hepatic encephalopathy, where the liver is not able to filter toxins that it normally does out of the blood. So these toxins build up and can make the patient confused, forgetful, even like combative, as you can see here in this cartoon. It can cause jaundice, that yellowing of the skin and eyes in patients. And again, it can cause this fluid buildup in the abdomen that we call ascites. And these are these main decompensations of cirrhosis. That's when you have decompensated cirrhosis. So how do we assess how sick someone is once they have cirrhosis? And that's when we look at what's called the MELD score. The MELD score stands for Model of End-Stage Liver Disease. This score, the highest it goes is 40, and the lowest it goes is 6. The higher the score, the sicker the patient. So this is a score that usually determine how sick someone is, and when they're on that liver transplant list, it tells them, we grade them on the list based off that score. So if you are on the list for transplant, the higher your score, the higher you're going to be on the list and closer to transplant. However, this strictly involves blood work. It doesn't take into account all those other complications we talked about. And the blood work, it includes some of the liver function tests we talked about, as well as some of the kidney function tests. It takes into account creatinine. It takes into account the bilirubin, the INR, the liver's clotting ability, the blood sodium, and the albumin. And we put it into a calculator, and it spits out a number from 40 to 6. So moving on to kind of some of the other terms that I really want you to kind of be familiar with when it comes to liver disease. Fatty liver. Fatty liver is the most common cause of liver disease in America. And it's often the more technical term that we use is steatosis, and you'll see kind of below what we mean by that. So steatosis and fat are the same thing. It means the same thing. So two ways that fat or steatosis occurs in the liver. One is alcohol, and we'll talk a little bit more about that in the next coming slides. And the other one are metabolic causes, or causes of metabolic dysfunction, such as diabetes, high blood pressure, high cholesterol, cardiovascular disease, and so on and so forth. So the terms that we have here is metabolic dysfunction associated steatic liver disease. And these are mouthfuls, or MASLD, metabolic dysfunction associated steatohepatitis, or MASH. So in MASLD, yes, you have a fatty liver, and you have a steatic liver, but your liver enzymes are normal. There's no hepatitis, there's no inflammation. Then that can progress to a MASH. Now that fat is causing an inflammation. Okay. Then you also have alcoholic liver disease. That's from alcohol causing that fat to kind of form in there. But then you could have a combination of these two, where someone has the risk factors. They may have diabetes, but they're drinking a lot, and that causes the overall liver disease there. So that's the combo issue there. So going forward here, we're talking about MASH to MASLD to MASH to cirrhosis. So how does this process occur? So initially, we're presumably and hopefully and mostly, we're all born with a healthy liver. However, as we develop metabolic disorders like diabetes, high blood pressure, high cholesterol, obesity, fat accumulates in the liver. Okay, and this happens at about 20 to 30% of the general population. So at first, fat is just there. It's not doing anything. But as this persists, as years go by of fat being in the liver, you have a patient having uncontrolled obesity or metabolic disorders, about 7 to 30%, and that's a big range, can now develop MASH, a steatosis plus inflammation. This is a fatty hepatitis. Now the fat is causing inflammation. So now the liver enzymes are elevated. So as this progresses, you develop that fibrosis and can lead to liver cirrhosis and even liver cancer. So it's important to understand that this is a progression here. And this line right here, before you get to cirrhosis, this is the point of no return once you develop cirrhosis. But any point here, you could, if you make changes to the metabolic disorders, you could roll this back and even get back to a normal, healthy liver over time. This is kind of a busy slide here, but kind of going over kind of what we talked about here. Another way to kind of put it, we had the MASLD, the metabolic dysfunction associated steatic liver disease. You have the alcohol, metabolic and alcohol, and you have the alcohol. And then you have a couple other things that can cause fatty liver that are not alcohol metabolic related, such as certain drug-induced liver injuries, or sometimes cryptogenic. People just develop it. It's a genetic predisposition to it. So going back to MASLD or MASH, it is a risk of cirrhosis and liver cancer for sure. So that's why oftentimes people are like, yeah, I have a fatty liver, but what's the big deal? This is the big deal. It can lead to cirrhosis and liver cancer. But in addition to that, outside of the liver, if someone has this type of steatic liver, this fatty liver, not only can they develop cirrhosis and liver cancer, but they can develop, if they already don't have it, diabetes, heart attack, stroke, high cholesterol, high blood pressure, all the metabolic syndrome. And linking this, if you see, these are also risk factors for kidney disease as well, as you can see here. So you have, everything is kind of linked and kind of morphed together that we have to kind of understand here. So going on to alcoholic liver disease, we have to talk about alcohol use disorder. Now, this is a busy slide, and this is kind of diagnostic stuff that we talked about here. But one thing to remember is that we don't call it alcoholism. We don't call it alcoholics, patients like that. We know that when people excessively drink, it is a disease. It's a disease like any other, like diabetes, like high blood pressure, like high cholesterol, like cancer. And like any of those, they all have specific treatments, as do this. So we have to understand that alcohol use disorder is a mental health disease. And it's one of those things where people cannot just say, oh, I'm going to stop drinking because, I'm strong, I could do it, or I'm weak, I can't do it. It's not about being strong or weak. This is a mental health disease, and it needs a treatment. You just can't stop drinking isn't the treatment. Getting the help as to why someone is drinking so excessively is the point. And it's a mental disease. You have to kind of dig back and get that treatment with therapy or rehab to peel back that onion that is us as a human, and finding out what really makes them tick. Why did they drink so much to cause liver disease and whatnot? So kind of going on to this, what are the risk factors for alcoholic liver disease? So it's really alcohol above the threshold. And what is the threshold? It's 1 standard drink a day for women, 2 standard drinks a day for men. Now, what is a standard drink? That's 14 grams of alcohol. Now, what does that mean? I don't know anybody who counts the grams of alcohol, but we'll kind of translate this out. So 1 standard drink of 14 grams is 1 12-ounce can of beer. It's 8 to 9 ounces of malt liquor, 5 ounces of table wine, or 1.5 fluid ounces of any kind of 80 proof spirits. So excessive drinking would be more than, for men, more than 2 beers, 12-ounce beers a day, or for women, just 1. It would be wine, 5 ounces for women, 10 ounces for men. So that's important to kind of look at. So oftentimes people are at risk for alcoholic liver disease if they're daily drinking while fasting, or that binge heavy drinking on the weekends or so. Smoking cigarettes also increases the risk of, along with drinking, increases the risk of developing alcoholic liver disease. This tends to happen more women as men. As you can see, women have a less of a tolerance of a threshold there. There are some genetic components as well that can put someone at a higher risk for developing alcoholic liver disease, as well as if they have an increased body mass index, if they have obesity or other liver diseases, then they can get it. So one thing to remember is that if they have other liver diseases, viral hepatitis, or metabolic associated steatic liver disease, that fatty liver disease, there's no safe amount of alcohol. Now, oftentimes you heard that people are like, hey, doc, I get it, but I drink for my heart. It's important. Now, in 2021, kind of still in the middle of the pandemic, the American Heart Association walked that back and said that, the risk of, that glass of wine in some people with these risk factors is actually more of a risk to their health than benefit. So they have walked back that guidance of, a glass of wine for your heart. So yes, this is definitely excessive alcohol here. So when we mean glass of wine, we just don't mean this giant chalice. It's really 5 ounces or so. So alcoholic hepatitis. What is alcoholic hepatitis? Alcoholic hepatitis is when there's acute liver inflammation. And sometimes it can be need for a liver transplant as well. We know that as little as 6 months of heavy alcohol use can cause alcoholic hepatitis. What is heavy use? We talked about above the standard, but this is beyond that. So now we're talking about 3 standard drinks for women and 4 standard drinks a day for men. It puts them at risk for developing really bad inflammation of the liver that can cause liver failure and the need for a liver transplantation. So again, this is kind of something, your liver listening to you tell your doctor you only have 1 to 2 drinks a week. But, we have to be, so a lot of what I tell my patients is that the only way we're going to move forward with helping you is honesty. You be honest, I'll be honest, and that's where we can help you. If we're not being honest, we're not going to be able to help you out with this and help treat your disease. And there's never any judgment in the sense that, hey, no one ever judges you for your drinking. We understand it's a disease, and we want to help you kind of get past that. So going on to alcoholic liver disease epidemiology. So, we've been seeing a lot more of this going across since the pandemic as well. So we know, in early 2000s, we were seeing in about 12 months, about 8.5% of patients. And then later in 2012, 2013, this rose to about 12%. So that's a 49% increase. And then the pandemic, things really, really got bad. Online sales of alcohol went up, as well as alcohol. And with that, alcohol-related hospitalizations and mortality increased post-pandemic as well. And we saw a lot of women with increased hospitalizations and death due to alcoholic hepatitis. And alcoholic liver disease became the leading indication for liver transplantation. So people often talk to, there's another slide here, I kind of want to talk about the glass of wine going with that chalice there. If you can see here, you can see over the centuries, even how much bigger the wine glasses have become. And you can see here, even this, I mean, the glasses, the size of the glasses have increased beyond this. So obviously there's going to be kind of an overuse of alcohol, understandably. So kind of going to, we were talking about why did alcohol use disorder increase over the last several years? Well, there was a mass traumatic event. I think we all remember COVID-19, even though if we want to forget it. You know, that increased short-term increases in alcohol. There was a lot of financial insecurity for folks, unemployment, and then that kind of increased substance. That we know that increases substance use disorders. There's psychological distress, isolation, a lot of group therapies like AA couldn't meet in person because we were all socially isolating, right? Socially distancing. And then certain residential treatments and inpatient rehabs that people would want to go to, where essentially a lot of them were closed because of COVID. So kind of moving on, it's important for alcohol use disorder improve, we have to improve our public health messaging. Often people in certain European countries have noticed a reduction of alcohol use disorder and alcoholic liver disease with higher taxation on alcohol. It's important for primary care doctors to screen patients, that they're often the first line here with different tools to screen for them. And then we need to be better about just treating these patients and reducing and recognizing it, and not kind of pushing it under the table here. Moving on to viral hepatitis. Now remember, I said that this is often what, in my experience, when patients hear hepatitis, this is what they think of. But as we said, there's many flavors of hepatitis, and viral hepatitis being just one of those flavors. So hepatitis A, what is hepatitis A? So hepatitis A is a virus that causes inflammation of the liver. It occurs when a patient who's uninfected or unvaccinated, we'll talk about the vaccine, ingest food or water that is contaminated with something really, really gross, the feces of an infected person. So if you have unsafe water or food, inadequate sanitation, or poor personal hygiene, or oral anal sex, those patients those people are increased risk for this. Now there is a vaccine to this, so that's the one thing to kind of make sure you kind of see your primary doctor, or even your local health department can provide this vaccine. Usually this is what we call self-limited. It kind of gets better on its own. But if someone has some kind of underlying liver disease of any of the previous ones, this can unfortunately be fatal and may even require a liver transplantation to avoid being fatal. Moving on to hepatitis B. This is a virus that spreads from blood, semen, and other bodily fluids. So sexual contact, sharing of needles and syringes or other drug injection equipment, but also from mother to baby at birth, because we know there's a lot of fluid and blood exchange at that time. There's no cure to hepatitis B. However, there is treatment and especially vaccination to prevent people from getting this. Now, hepatitis B can progress to cirrhosis. Patients can develop liver cancer even without cirrhosis. And in the acute setting, when someone first gets it, it can cause acute liver failure, or a flare of it years down the line can cause acute liver failure, often needing a liver transplantation as well. Now, hepatitis C, this is something that's contracted blood to blood, so not through bodily fluids as much. And big risk factor here is IV drug use. It's rare to transmit it sexually, less than 2%, but you have to remember that's not 0%. So I tell my patients who have hepatitis C, it's important that if you're going to be sexually active, to use barrier protection until it is treated. Because yes, we do have a treatment and a cure for this. This rarely causes acute liver failure, but the main thing is causes chronic liver dysfunction, eventually to cirrhosis and liver cancer. But like I said, we have a cure for this here. The cure really is a very easy treatment. So there's basically essentially two or three treatments that are one is one pill. The two are one pill a day for 12 weeks at a time with close to 100% cure rates. The other treatment is just 3 pills all at once for 8 weeks of treatment, again with close to 100% cure rates. Patients with hepatitis C, I think the big thing is, we have a lot of that in our kind of the DMV, DC community here, mostly because of a lot of the unfortunate, IV drug use here. So, I think a lot of things that we see here is that patients may have it, but may have a stigma, may be worried that maybe I shouldn't get treated if I'm still using IV drugs. But we know that the treatment for hepatitis C, the cure for hepatitis C, the medication that we use can be used if you're still using IV drugs as well. But we do treat them because so that we don't make sure that it doesn't spread out from anyone else there too. So again, a lot of this is about the stigma. We talked about the stigma of alcohol use disorder. We want to kind of mention, I know there's a stigma around IV drug use as well, but that what I mean to say is that shouldn't, and I hopefully won't prevent patients who have this from seeking treatment. So lastly, I kind of wanted to touch on kind of some of the procedures that liver patients may get and what it means. We often talk about a liver biopsy. What is a liver biopsy? So essentially, in this cartoon you can see here, the patient may get a little bit of sedation, definitely some local anesthetic, and the doctor will take a needle, kind of look with the ultrasound first to see what's going on with the liver, and put a needle in, get a sample of the liver out. There are some small risks with it, small risk of bleeding, particularly if patients are on blood thinners or have more advanced liver disease and whatnot. But usually it's very well tolerated and no major issues. People often ask me, I've never had one done. People often ask me, what does it feel like? But I can tell from what other patients say, it feels like someone's punched them really hard on this right side over here. But I will tell you, most women will say it's not worse than giving birth. So that's always a plus there. Like I said, I'm not giving birth, so I can't tell you, but I'm just telling you what patients have told me. Alternatively, this is a FibroScan. This is a machine that we actually have here in our office that can non-invasively, without cutting you, look and tell how much scarring there is in the liver or how much fat is in the liver. We've positioned patients in this kind of way here, and basically this probe here pushes sound waves through the liver, and those sound waves kind of then are interpreted by the machine and can tell us how much fibrosis from that stage 0 to 4 there is, and how much fat there is in the liver, all without having to cut you open and finding those results out in real time. If for any reason you are told by your doctor to come back for a FibroScan, please remember to not eat or drink anything for about 3 hours beforehand, because if you do have a full stomach, as you know, our liver is involved with digestion. Activity within the liver can overestimate the amount of scarring in the liver. We don't want to overestimate anybody or underestimate anybody. Now, endoscopy, often known as EGD, the esophagogastroduodenoscopy or upper gastroendoscopy. Basically, this is that upper scope that we talk about, that we may do when patients have liver disease, to look for those varices that we saw in that picture of them bleeding. So you will be put to sleep, laid on your side. They often put something in between your mouth to protect your teeth and keep you from biting us. And we'll take a look with the camera down at your stomach, at the first part of your small intestines. The other procedure I kind of wanted to mention was a paracentesis. As you saw in the previous picture earlier in the presentation of that patient with the distended belly with the ascites. Sometimes what we have to do is sample that fluid out of the belly to make sure it's not infected or to figure out what's causing that fluid. So this is kind of something that we say. We don't need to sedate a patient for this. We also do this in the office. We give some local anesthetic here and can take off that fluid. Also for comfort, sometimes for patients that get so swollen and feel uncomfortable, we can remove that fluid to make them feel better, test it to make sure it's not infected. So these are major procedures for the most part that we perform within a liver practice for the most part. So that kind of concludes the presentation of the liver terms that everyone must know or should know. Do we have any questions from the folks online? Dr. Melanson, any questions from you, sir?
Yes, Dr. Vahora. First of all, what a masterful presentation. It was really encyclopedic. You covered everything. And, I've heard you speak many times, and I always learn something when I hear your presentation. So thank you for presenting for our audience here, and I'm sure there are lots of great questions coming from the audience. But I'll start with one that I thought of. You know, I've seen patients throughout my career that wind up having fatty liver disease. And so my question is, you know, you did a good job of covering how fatty liver disease can go from just having fat in the liver all the way up to hepatitis and beyond. But my question is, I've seen thin patients with fatty liver disease, and so are you always able to find a metabolic cause, some sort of metabolic dysfunction in patients that have fatty liver disease, even when they're thin?
So that's a great question, and and I do see that often as well. We know that there are certain genetic predispositions to developing fatty liver disease that can occur, and then of course there's always what we call cryptogenic steatic liver disease, where these patients don't have any of these metabolic risk factors. They don't have diabetes. They're not overweight or obese. You know, they don't have high cholesterol or anything like that, and they just develop it. We know that there's certain genetic factors kind of that can predispose patients for that in particular. But sometimes there are certain medications that can still do it as well. But it's either usually if it's not related to the metabolic syndrome, it's usually what we say cryptogenic or related to medications or something of that sort.
Awesome. Thank you, Dr. Verhoor. We do have another question that's coming from the audience. This is from Luke Rojas. How does horseshoe kidney and liver disease have a common thread, cause, cures, etc.? How are they related?
That's a great question. Horseshoe kidneys and liver disease. You know, oftentimes these patients may have, a lot of times they may develop also kind of certain types of fatty liver disease as well, because they have other issues such as hypertension or hyperlipidemia, high cholesterol, and things like that. So what I've seen with the horseshoe kidney, I've not seen much in my practice, but the few times that I've seen it with a patient with liver disease has been related to fatty liver disease as well. Dr. Melanson, I know you in your kidney practice, have you seen any kind of links between this, and what's your experience with this?
Yeah, you know, I was just thinking as I'm reading that question, I've not seen it. You know, horseshoe kidneys, which is it's a congenital thing, right? So you know, you could think of, you know, I used to treat a lot of pediatric patients, and so every now and again you'd see someone with horseshoe kidneys. However, I don't remember any syndromes where, because you know these kids can get syndromes where they have liver disease and kidney disease, but specifically horseshoe kidneys along with some sort of congenital liver problem. Off the top of my head, I don't remember seeing it. And you're right. I mean, you can see fatty liver with anything, but maybe Dr. Callender knows. Dr. Callender, you know, he's been around a lot longer. Maybe he's seen this. You're on mute, Dr. Callender.
Oh, okay. Can you hear me now?
Yes.
Yeah. I've been around a lot longer, but I'll admit to you that I've seen a number of horseshoe kidneys, but none associated with liver disease.
Yeah, like I said, I've only seen it in few patients who have the concomitant risk factors for fatty liver, but nothing that's significantly just associated with horseshoe kidney.
Well, since we're on the topic of the horseshoe kidney, can we talk about any similarities with kidney and liver disease? Do you see patients coming in with both, and how would you advise them from there?
Absolutely. So, you know, as we mentioned, there was that link. We were talking about the metabolic syndrome and the risk factors for fatty liver disease, and that could also lead to kidney disease. We know diabetes, high blood pressure, you know, that metabolic syndrome, you know, that those are often causes of patients developing kidney disease. So that there are also risk factors for patients developing that steatic liver disease or a fatty liver disease. The other side of it is, yes, oftentimes patients, once they develop cirrhosis, there is a entity called a hepatorenal syndrome, that liver kidney syndrome, that can be associated with cirrhosis. So, and that often gets better. Most times that gets better once you treat the liver disease. So it's just, if someone has liver cirrhosis and that liver kidney syndrome, if they undergo a liver transplant, their kidneys get better as well. They don't often get transplant as well, even if they may have been on dialysis for that. That we notice that sometimes their kidneys can, in fact, recover.
Yeah, Suna, I'm sorry, I'll just push ahead because I want to ask Dr. Vohora this question because I just came back from a conference, and a lot of, at least the paper that I discussed, was this interaction between obesity and kidney disease. And obviously, like you said, fatty liver is now the main cause for liver disease. And I'm just wondering, particularly in America, but I'm sure this happens throughout the world, this interaction between psychiatric issues, issues of the mind, and problems that we will deal with, even surgical. I'm just wondering, are you guys, do you have a psychiatrist that works with your patients? Because, when you start talking about things like drug abuse and alcohol, well, what do you call it now? It's not alcoholism. What do you
alcohol use disorder.
What do you call it? I mean, you got all these fancy words now. We used to just
alcohol use disorder.
Alcohol use disorder.
Oh yeah, okay. Alcohol use disorder. So you got alcohol use disorder. We used to call people obese. What is body dysmorphic syndrome or what? But I mean, the point is, people are overweight. They drink too much. They take control. How do you deal with those issues, Dr. Vohora? I mean, you didn't train as a psychiatrist, so what are you doing with those issues of the brain that lead to health issues? You understand my point?
Absolutely. And I would say, before coming to DC, I was in Dallas for 6 years, and prior to that in North Carolina. And this is something that's all across the country. You were right. A lot of the issues with, if it's the metabolic associated static liver disease, yes, we know there's a genetic component, but some of it is related to mental health, right? Alcohol use disorder, it is a mental health disease, right? So it needs to be addressed from that. So it's really, really hard because right now the mental health system in our country, I will get on my soapbox here, is broken. For my patients, it's so hard for them to find a psychiatrist or a therapist who takes insurance. Everyone's cash based, and no one's got $100, $200 just to palm off for every session, and it's really unfair and unfortunate. Now, there are some local resources, nonprofits that do provide that help. Obviously, there's AA. I often recommend that to patients because it's free. It's there, and we know that it works. Now, however, AA has a faith-based background with it, and that doesn't fit for everybody. And a lot of patients don't want to meet in a group and do things that way. And I understand that, everyone's a little bit different, which makes it hard because that's like the main one. But there are other things in the community that are out there. I know there's a lot of faith-based organizations that really do stuff. A lot of churches are doing a lot of good work in helping their congregations get kind of help with both just any kind of mental health disorders, alcoholic, from narcotic abuse, as well as obesity and healthy eating and things like that. So really, it's about looking into kind of what's in the area and what's available from there. That being said, sometimes you're right. I haven't trained as a therapist or a psychiatrist, but a lot of my practice is really kind of talking to patients about this and getting on their level, because that's what they need, and that need can't be filled anywhere else. So it's been a little bit of an on the job training, so to speak. But the big thing to understand is that there is it's easy for me to say that, but that we don't stigmatize, we don't judge you for any of this. We understand it's a disease. We are there for you. We're spending time because we care. We're not gonna just kind of poo-poo you off, and we'll try to find the resources for you in the area to get for you.
Yeah. I love what you said, Dr. Vahora, when you said that you don't judge. And I think, a lot of individuals, you've gone over alcohol use disorder and the different variations. But when somebody comes into a physician's office and may have a disease based on their usage, it may come with some stigmas, but to know that there are doctors, and everyone listening, there are doctors' offices who are trained at every level to handle every type of, there's no situation that is new to any of the doctors here on this screen. So if that is what's preventing you from going and seeing a doctor, please do not let that be a hindrance, because there are resources available that we can provide, or any provider in your area can refer to you. So we had another question come in from an audience member. I want to make sure.
One more thing, if you don't mind, Suna. Like I said, mentioned before, and Suna, thank you for saying that. As I mentioned, if you have been told you have hepatitis C, hepatitis B, and you're still, you're having a hard time kicking the habit of using in drugs, still come in and see us.
Yes.
We will still treat you. We're not going to stigmatize you for that. And we may be able to help you get off of it as well. If you are still drinking and you've been told you have liver disease, still come in to see us.
Yeah.
There's things that we can do to help you with that. So it doesn't mean that we need to wait until you're completely stop drinking or stop using to see you and treat you. We still want to see you, because we can help you provide the instructions and give you resources that can help you with the mental health disease as well as the underlying liver disease.
Absolutely. Thank you, Dr. Vahora. Let's get this next question on the screen so we can go ahead and answer it from our audience, I believe from Facebook. All right. If you caught a kidney problem in its first stage, can it be reversed? I love this question. Great question. Dr. Callender, can you answer this one?
Well, actually, I'd like to answer it, but of course, Dr. Melanson, that's his baby. So
Okay.
I'll defer to him.
Okay, Dr. Melanson.
Yeah, and Dr. Callender knows that we, using his model of going out and interacting with people in the community, MOTEP, they basically were the blueprint for this. And now with the Ron and Joy poll, a big part of what we do is go out into the community to diagnose early kidney disease.
Yes.
Similar to liver disease, there are 5 stages of kidney disease, right? And just like liver disease, the first 3 stages are reversible. So stage 1 kidney disease, which unfortunately most people with stage 1, they don't even get diagnosed because it's usually missed, even by doctors. So stage 1 kidney disease is absolutely 100% reversible. And it's really just like Dr. Vahora said with liver disease, it's about treating the underlying cause. So you treat it and then you can reverse it. And usually the most common thing is going to be that the person has either undiagnosed or diagnosed high blood pressure. And so what the first thing you need to do is treat their high blood pressure or their diabetes and then follow up. And that's the thing, people need to follow up. I always say the most important appointment with a physician is the follow-up appointment, right? We need a lot of information. We're going to want to get lab work. We're going to want to get urinalysis. And then we're going to need to discuss that with you. And then we're going to have to follow up and see if the changes have taken place. Is the medicine working? Is your blood pressure now under control? There's a lot of blood pressure medicines, and there's a lot of trial and error that you have to do in order to make sure that the person is being well treated. But I don't want to go on and on. But the point is, absolutely, without a doubt, first 3 stages of kidney disease, absolutely reversible.
Yes, absolutely. And I love that question, and that the audience member, that is exactly what you should be asking yourself. Whether it's kidney or liver disease, what point can I make sure that if ever I can go back and not have to progress to a stage where you're talking about transplantation? Because I work in the field of liver LPIC and liver transplantation, I wanted to go back to Dr. Vahora. In the similar sense, we do outreach in the community with, protein analysis for liver disease. What type of prevention can be done, or what type of testing can be done preemptively before someone is diagnosed with liver disease? What can they ask their doctor to be screened for if they want to make sure that they don't have any type of ailments of liver disease?
Absolutely. So I think the biggest things are obviously they could ask their doctor simple blood tests to check their liver tests. That's one. If there's any abnormality, then we can go forward. The other thing is with doctors, and a lot of it's on the patient themselves to understand what they can do. Like I said, honesty is going to be the best way to kind of get things kind of going here. You have to be honest with yourself. If you are drinking, how much are you drinking? Has it been a problem? And be honest with your primary doctor so that they can get the tests done to see what's going on and then get you to the right folks from there. As in terms of prevention, making sure we know we have vaccines to hepatitis A and B, and to making sure that patients can get these vaccinations from their primary doctor. And I know a lot of local health departments also provide that for free to patients, the vaccinations for hepatitis A and B, and that's definitely a key to make sure you can prevent things. And kind of going back to what was said before, Dr. Milano-san was saying, yes, we in the previous question, we know that a lot of these diseases until a certain point can be reversed, but the key is early identification. Understanding that there is a problem, or going to see your doctor, following up so that you can go and get this stuff done, so you can understand that you have a disease, and then you could own it. And if the patients own the disease, understand, hey, I have this, I'm taking control of it, and I'm gonna beat it and do what it takes to reverse it and not get to the point of no return. That's the key.
Awesome. Thank you. So yes, Dr. Calendar. You're muted, sir.
One of the issues that I've encountered over time is that while we talk about alcohol abuse disorder, there's some patients who have imbibed in alcohol so much to the point that when they come in, they actually need a liver transplant at that point. But there are centers that will tell them that you cannot be transplanted until you stop drinking. What are your thoughts about what percentage of centers in the United States would allow somebody who actually has not stopped drinking, but who has decompensated liver disease and needs a liver transplant, that would actually transplant them under those circumstances? And what percentage of transplant centers would force them to stop drinking before they are actually become transplant candidates?
That's a great question, Dr. Calendar. And I wish I could say it's as clear cut as I could give kind of a yes, no, this is what it is. It's much more of a complicated answer. What it comes down to is, yes, I would say majority of centers right now don't have that 6-month sobriety rule anymore. Previously, there used to be all transplant centers kind of had a rule where you had to be sober for 6 months before you could even be considered for a liver transplantation. And what we realized, and the reason why that rule was there, was that we realized that if someone was sober for 6 months, their liver may recover to the point where they may not need a transplant. But we also were losing a lot of patients who were dying. So we looked at and we also saw that 6 months of being sober wasn't a good predictor of them staying sober after a transplant. So there were a lot of studies done, and one landmark study done out of France that really looked at this and said, what is a good predictor of sobriety, of someone staying sober after transplant? And what they looked at was not how long they were sober before transplant, but there were several factors. One of the factors being insight into what? Alcohol use, their alcohol use or their disease process. Them realizing, hey, I get it. This is what caused the problem. And now I'm going to stop drinking and do whatever it takes to prevent myself to go back to drinking. That's one. Second thing was support, family support, friends support, being around people who are going to be able to help that patient stay sober. They understand that, hey, you know what, from here on out, if my family member, my friend is going to get a liver transplant, they have alcohol use disorder as a disease, we're going to help them stay sober. Christmas is going to be sober. New Year's, there's no champagne. With the wedding, there's no wine at the wedding, that type of thing. So we know those patients tend to do better. And then we also look at, has the patient, how much has the alcohol really affected their day to day? Have they burned their bridges with the rest of the family, have lost their social support? Have they lost their job, had multiple DUIs? Those patients are a little bit more on the high risk end. But I will say most centers right now will at least give patients a fair chance, evaluate them, and say, hey, you are or are not a candidate right now. And sometimes patients come in so sick that, then unfortunately, if they're not a candidate at that time, they're not going to get an organ. They may pass. But a lot of times, the good news is sometimes patients come in. We tell them you're not a candidate right now. We give them, they see our social workers who can provide a plan for them, a customized plan for them to get treatment for the alcohol use disorder. They not only stay sober, but they gain the insight they need to treat their alcohol use disorder. And then they will become a cancer at that time. Once we kind of create a plan for them to stay sober and treat the underlying liver disease.
Let me ask another question, which is something that our group really discussed, which is if after you get the liver transplant, you start drinking again, and your liver fails again, are you a candidate for a second liver transplantation?
That's a great question. And I will say, unfortunately, across my career, I've seen this a few times, and luckily it's just been a few times. Most times, I will say it really just depends on the circumstances of the patient and whatnot. But most times, I will say, unfortunately, in my experience, from what I've seen as patients, they have not been able to get another transplant in that scenario. Now, the biggest thing comes down to is how do we prevent that patient from getting to that point? Do we have ways to prevent that patient from getting to that point of needing another liver transplant? Because in honesty, the average across the world, I think not just nationally, but across the world, it's about probably like 20 to 30% of patients will relapse at some point. But the question comes down to, is it just one drink or a couple of drinks, or is it sustained relapse? The one or two drinks isn't going to make that liver, and usually shouldn't make that liver fail. It depends on how much they're having at that time. But the key is identifying the patients at risk beforehand, putting them on a plan, and then surveilling them afterwards. Because we have ways to test patients to see if they've been drinking within the last 4 weeks, blood tests to figure that out. So we don't use it as a punitive tool, but we use it as a tool if they do pop positive on that test to get them the resources they need. Pull in their family, pull in that support system that was there before transplant, and that there should be there after transplant. Get them to see our social workers, get them to kind of do it, kind of help with that. Luckily, with that, in my career, I can only probably right now think off the top of my head, probably 2 patients that have gone on, failed all those interventions, and gone on to develop liver disease after cirrhosis after the transplant, and then passed because they did not get another transplant because they were kind of very high risk from that side of things. But
it's interesting that
I'm sorry.
We had a transplant group of patients who had transplants, and we asked them the question: if the patient came in for a retransplant and they had done the same drinking patterns that they had before the transplant, would your group be agreeable to them having a second transplant? And to my surprise, the patients felt that this would be a waste of a liver. Anyway, it's just to share that how some of the patients felt about it, even though that may not have been the correct position.
Yeah, it's a tough situation, and there's a lot of controversy involved with this, especially because most of the times with liver, especially when these patients are so sick, they're getting deceased organs. It's not a living donation, and so there's a shortage of organs. I wish we could say we could just reach up to the cupboard and pull out organ for everybody. I wish I could do that. I mean, but because of that, we have to be. There is that really, really strict and thorough evaluation process to make sure these patients are going to do well.
Thank you so much, Dr. Vahora. Wonderful presentation. I'm going to put a selfless plug. If you're not an organ donor by now from listening to this show, please make sure you learn about organ donation and becoming an organ donor. Okay.
Please, yeah.
So thank you for your presentation on liver terms that everyone should know. Dr. Melanson and Dr. Calendar, thank you so much for your input and expertise. You've made a tremendous impact on our audience and me as well. And to you viewers, thank you so much for joining us today for another edition of Kidney Talks with the GW.
Wait. Suna, I just want. Can I ask one more question? Before
yeah, sure.
All right. I got two quick questions, Dr. Vahora. So, the first question is all alcohol the same? In other words, I mean, you have a person that's drinking, say, malt liquor or something like that, and they drink a lot of malt liquor. Obviously, that's bad. You could become needing a liver disease because of cirrhosis. But what if they're drinking like really exquisite French wine, or like really fine cognac or whiskey? I mean, they're not in the same category, right? So that alcohol doesn't damage the liver in the same way, I don't think.
Well,
but that's the first question. But then my second question is, I've talked to you about Tylenol, acetaminophen, and I know that's toxic. That can be toxic to the liver in high dosages. But I'm wondering about, as I get older, and I work out, sometimes I have to take Tylenol, sometimes more than once, like more than 1 day in a row. And I'm just wondering, is there a risk over time? Like, even if you're not taking a big dose, but if you're taking it for, say, a couple of days in a row, does that increase your risk? So those are my two questions.
I'll answer the second one first. So Tylenol, if someone has liver disease, we limit it to 2,000 milligrams or 2 grams a day in 24 hours. That's the limit. If someone does not have liver disease, it's about 3 to 4 grams, and more literature is going to 3 grams or 3,000 milligrams a day. So that's kind of where things are with Tylenol. Tylenol otherwise is a safe medication as long as you're not taking too much of it all at once. If you're taking, 650 every day, it's not a problem. But when you take a whole bunch of it all at once, that's when the problem occurs. Now, in terms of alcohol, alcohol use disorder is a disease that does not look at someone's wallet, does not look at their bank balance, does not look at if they're drinking, the top shelf stuff or the stuff that they get at Walmart. It doesn't matter. Now, the thing is this. Beer
that can't be right.
12 ounces of beer, 12 ounces of beer. 5 ounces of table wine, whether you're getting it out of a box or out of some French chateau or whatever, 5 ounces is 5 ounces. That is the standard grip. Whether you're drinking, I don't know much about liquor. I don't drink. I tell people I'm a bad liver doctor. I don't drink, but I don't know the spirits or whiskeys and something. 1.5 ounces, 80 proof is 1.5 ounces of wherever you're getting it from.
Awesome.
Okay. Thank you, Dr. Orr.
And then last question that's coming from the audience: supplements. We haven't talked much about supplements here. Are there any supplements or vitamins that users could take to help strengthen them and aid in the prevention of liver disease?
I'm glad you brought this up. I was kind of tempted. I wasn't sure if we put this on in the presentation. I didn't want it to go too long. But so supplements are called supplements for a reason. They're not a food or a drug, and therefore they're not regulated by the Food and Drug Administration. Oftentimes, I would say at least once, and where I was previously, and here you get usually at least once or twice a year, we see a patient with acute liver failure, fulminant hepatic failure from just supplements alone. So the best thing for your liver, folks, if you can see anything from the theme here, is to remove the insult. If you're drinking too much, remove the alcohol. If you have metabolic or diabetes, remove the sugar, remove the fat. That's what's good. Your liver does better by taking things away, but not by adding things. If you have viral hepatitis, take away the virus. So a lot of it is your liver needs less, not more. And with more, you run the risk of causing issues with the liver. So you may go to GNC, Amazon, liver detox this, liver cleanse this, all this kind of stuff. Is ginseng good? Is turmeric good? Is was it milk thistle? I will tell you, don't waste your money, please. You're just going to cause more trouble. Take away the stuff as opposed to adding stuff.
That is so good, Dr. Vahora. And this is coming straight from a liver doctor. This is not a paid ad. This is not a commercial. No one is getting paid. This is directly from a leading doctor in the field. So you can trust our opinion. And so before we move on, any other questions, any comments before we close out the show? This was amazing. I feel like we have to come back and do another one on liver. Lots of good questions and conversation.
We might have to change the liver and kidney tops, or kidney and liver tops. Then, if you ever come back again, I want joint heading. Then, okay.
Well, we haven't done that before, so I think that's a great idea. Thought about here. Perfect.
There we go.
Well, without further ado, again, thank you so much, listeners and
Thank you
audience
so much
members, for joining us today. Dr. Vahora, Dr. Malonzo, and Dr. Callender, thank you so much for an enlightening conversation. On behalf of the GW Ron and Joy Paul Kidney Center, MOTEP, the Minority Tissue Transplant Education Program, and the Pennsylvania Avenue Baptist Church, along with blackdoctor.org, we thank you for being a participant here today. We will be skipping our next webinar in observance for the holidays. So you will see us in the new year of 2024 on January 12th. We hope that you and your families are safe and have a wonderful holiday season. Thank you.
Happy holidays.